CataractCoach.com, podcast series, episode number 65, with Dr. Juan Batlle, advancing ophthalmology at home in the Dominican Republic, but also bringing surgical advancements to you around the world. Welcome back to our Cataract Coach podcast. And today I have a very special guest, Dr. Juan Batlle from the Dominican Republic, who has an incredible story in ophthalmology, has done so much. In fact, a lot of the things you use in the operating room, the clinical trials were done in his clinic in the Dominican Republic. So Dr. Batlle, welcome to our podcast. So excited to have you here.
Dr. Devgan, I'm delighted. You know that I admire what you do through Cataract Coach. I'm one of your subscribers. I listen to what you have to say, but you know what I love the most? You love to teach, and I do too. So let's go for it.
Yeah, I love to teach. I love to learn. In fact, at my session at the Best of Cataract Coach at the AAS in Boston, we showed a case of Argentinian flag sign, and you brought up a very important point that a lot of us didn't realize. Tell us about that.
Well, the reason was at the session, if you remember, there was how would you manage this, and you do it all within 3 minutes. And you use the 27 gauge, you heavy viscoelastic, and you hold it down. But the point that I was trying to make, and of course I didn't have 3 minutes to do so, and that's why we're here today, was that you need to understand the physiology of the different chambers that have high pressure within the eye with the white cataract. And unless you understand that, it's impossible to do the surgery without getting into trouble.
So let's think about it. So in the intumescent white cataract, where the bag is full of liquefied lens cortex, the intralenticular pressure is high.
So let's begin before that. You have three chambers: the anterior chamber,
right,
the capsular bag, and the vitreous cavity.
Okay.
There's an equilibrium when the eye is closed. They reach equilibrium.
Okay.
However, when you do something like a paracentesis, the pressure in your anterior chamber goes to zero.
Right.
But that doesn't change the pressure in the vitreous cavity nor the pressure within the capsular bag. Okay. So then the wise surgeon says, I got it fixed. I'm just going to fill it up with viscoelastic, and it'll be heavy. That way I make it so tough and so hard, but what you end up doing is you're squeezing the intracapsular bag to the point that it's a balloon that's about to pop. So when I show you the slides, it's going to be very evident. So the idea is not to just increase the pressure in the anterior chamber, it's to somehow disinflate the bag before you go in. You need to disinflate the intracapsular pressure by a small puncture. And you see that with the YAG laser. People have done that with the YAG for years, saying this is the way to do it. Go to the YAG laser before to the operating room, puncture the anterior capsule, release the pressure, and then there's no problem with the Argentinian flag creation.
But so you say don't make a paracentesis. Instead, just go directly into the limbus with a small gauge needle.
30 gauge needle, correct, the yellow one.
So and you don't
even have to aspirate. You can, but you don't have to. All you got to do is puncture it. Go in and out, in and out. But you have to reach the place where the fluid is. Well, that was the Bobby Osher contribution. Remember, he used to say, well, the fluid is not subcapsular. It's between the epinucleus and the nucleus. That's where the fluid collection is.
Right.
And the needle has to reach that area. So all of a sudden you decompress the capsular bag.
Yeah, but if you have a video, we love to feature.
Well, I got videos, I've got slides, I got images. You're gonna love it. Let me bring it up if that's okay.
No, don't bring it up now.
Okay.
Don't bring it up now, please. We'll feature the video later. Let's just continue our conversation.
Okay.
Well, obviously, you have a big passion for ophthalmology, passion for even teaching ophthalmology, and I love to learn from you. But tell me, how did all this start? What was your path in ophthalmology?
Well, let's see. My father was a double ENT, trained in Presbyterian, New York Presbyterian College, Columbia University.
Wow.
During the Second World War, 1940 through 1948. And he came back to the DR, and he was the only board-certified ophthalmologist in the island. Most people think it's a small island. We have 11 million people in the Dominican Republic, plus 11 million more in Haiti. It's a huge island. So I went to school at Duke. Who got me there? The famous Dr. Wadsworth. He was my father's companion in the residency training program. But when I reached the age of going to medical school or college, he calls him and says, where should he go? And he said, well, obviously to Duke. So that's how I ended up starting Duke College, pre-med. And I would have a dinner with him about every 2 months. I was heavily mentored by Dr. Wadsworth and later by Dr. Norton when I came to Miami for ophthalmology. So I got into medical school at Duke after 3 years. My love was marine biology at the time, but I ended up learning a lot about research during my Duke years. I mean, Duke is really big on investigation. And then after that, I had the choices of where I would go, whether it was Iowa or whether it was Hopkins or whether it was New York, Boston, or Miami, but the closest to the island was Miami. Sure. And so Norton immediately picked up on it and said, "No, you need to go there." So Norton prepared me to come back to the DR.
How so?
Well, the DR only had intracapsular cataract surgery. There was not a single intraocular lens being placed in 1985. There was no microscope. There was no laser. There was no, I mean, we were so far behind in the country that it was obvious that something needed to change. So I was trained to do that. So I ended up doing 3 fellowships. I did neuro, I did retina vitreous, I did all the corneal transplants for almost 10 years in the country.
Wow.
I did orbits, I did fractures, I did tumors, I did examinations. I had to do everything when I came back. And so then my passion had always been cataract surgery, retinal surgery, and things in the anterior segment. But what happened was the country was loaded with glaucoma. We have a serious problem in the Caribbean with Afro-American ethnicity, and a lot of glaucoma. It's as high as 8% of the population.
Wow.
Male blacks has glaucoma. So that led me to the research and all those valves, being first in pilot studies for the PreserFlow. It was the focus microshunt then. Pilot studies for the glaucos. We did the first Transcends. When you remember, the Transcend went on to become the SiPass, and of course then it failed. And so now we're working on a new one for Gore, for Gore-Tex, which is going to be a substitute probably in the future for the Ahmed valve. Then in 2011, Buddy Culbertson came up to me from Bascom Palmer, my professor of anterior segment surgery, and said, would you like to try a laser that can do 5 of the 9 steps in cataract surgery with a femtosecond? And that was the catalyst. So we did from A to Z all the work for the catalyst way back in 2011. And that was approved by the FDA thereafter. And a great competitor was Lensex from Alcon. So we were par at one point in time. So that was the laser story. The other story in my background had to do with the amniotic membrane, because we discovered it here. We didn't discover the amniotic membrane. It was part of the human tissue, but a doctor from Venezuela had brought it from Russia. They were using this tissue that was the time of the glasnost, the perestroika, and the Russians wouldn't publish anything, and they had this membrane saved in a little vial with 95% alcohol that I had analyzed, and it was called the allotransplantat for conjunctivalplasty.
Oh.
So I took it to the microscope. My father-in-law did the pathology, and we got an acellular membrane. I can't tell you where it is because we don't have any a way of identifying the cells, because the cells were pycnotic from the alcohol. And but that in those days we had a delivery, and I picked up a placental membrane, and I took it to him under formaldehyde. He said, "Well, it could be, but it's too thick. It's 120 microns, but you brought me before was only 60 microns." And so then I divided the amnion from the chorion. It's like taking your tide and separating it into 2. And there we picked up on the amniotic membrane. And we tested it on 23 patients, took it to the academy, and that was the story. Then Schaefer said he invented it, but he got it from me.
Wow. So many different things that you really had an ability to kind of jumpstart there in the DR, the Dominican Republic.
It's really neat. Then I run a residency training program, a charity hospital that sees 900 to 1,000 patients a day. So
tell us about that. That's the Elias Santana Hospital. They're Maricanos.
That's right. So when I came, Willie Hunter was a missionary with the Christian Medical Society. And we had met in Miami when I was a chief resident in ophthalmology in 1984. And he said, when you finish, and if you want to work, we can do something. So I wrote up a 2-page, the model eye clinic paper on how you can make a school of ophthalmology to take care of the poor, where the residents could learn, where you could also do the famous research. Remember, patient care, research, and teaching. Those are the three ways you stand up on the chair. And so when we started, we would see like 30 patients a day. We thought that would be great, that we could solve all the problems. Then it would double every 3 months.
Oh, boy.
And it grew to where we see 1,000 patients a day. The initial donation for that charity hospital came from Dr. James P. Gills.
Oh, Jim Gills, fantastic.
And he bought the microscopes, the ophthalmology lanes, donated his ultrasound, the lasers. He donated $125,000 in 1985, and that has become the teaching institution. I now have 200 residents that have graduated. We're doing about 3,000 cataract operations per million per year in the country through all the people that have trained in that charity hospital.
Wow.
So
you're saying 900 to 1,000 patients of ophthalmology patients a day?
Just ophthalmology a day, yeah.
Wow, that's insane numbers.
Yeah. It's huge. And they're all poor. These are all people that otherwise would just go blind. There's just no option for them.
Well, then your residents must love it. It's such an incredible hands-on opportunity to operate.
Yeah, well, we have 10 residents per year. We used to take only 8. 4 of them are nationals. They're from the DR, and the other 4 are from everywhere. So we've had residents from Iraq, Iran, Azerbaijan, from Georgia, from every single South American country, most of the Central American countries. I mean, we've had a lot of people and many of them have gone back, create similar teaching scenarios in their countries. Rhino did it in Paraguay. Cesar did it up in Mexico. We have people in Costa Rica that are doing amazing work. Ecuador, Colombia. I mean, it's really something.
Wow, the ripple effect has gone so much from because you've been doing it for so many years. All those 200 residents are now teaching their own residents who are teaching their own residents.
So somebody said, Juan, how do you feel having seen all that? Oh, they would show all my. We just had a meeting this last weekend, and 80% of the people there at the meeting are graduates from my center. And so they had, how do you feel? I said, I'm like a stallion. I feel like these are all my children.
There's quite a number of children there. Now tell me, were all these trials that you were doing there?
Okay.
How do you ensure great patient follow-up? Because that's one of the big challenges in any trial.
Well, they can't leave the island, man. I mean, this is a biggest guarantee. It's that simple. But no, in the interview, we make them feel committed. So, like, for example, of the 23 original patients that we did for the Preserve Flow, some of them have passed away because it's been now 14 years. But yeah, most of them are still here in the island, and I can contact them. Plus, they're grateful because when they do well, it's easier to get a hold of them.
Right, because these patients are getting cutting edge, like you said, in 2011, they're getting the optometric femtosecond laser for free.
That's right. Everything. The ICL story is a beautiful one also.
Tell me about the ICL story, because now Evo ICL now is having really quite the good ramp up now. It's getting more and more.
That's a beautiful collaboration with California, because at the time, Alan Aker and David Brown were the consultants for STAR. STAR was in Pasadena, STAR Surgical. And so they had a version 3 ICL that had been tested in Buenos Aires and Mendoza, Argentina with Saldivar. And they had the version 3 tested in Europe. But it was so shallow, the vault was so low that the lens was touching the anterior lens capsule. And they were getting between 15 and 25% cataracts. For high myo, so that was not acceptable. But then they redesigned it into version 4 without the central hole. The original B4 was a 200 volt lens, and lo and behold, the cataract rate went down to 0.5 with the FDA study with 510 patients. Wow. So we knew we had it. And then years later, Shimizu and Saldivar says he did the first central flow hole in the ICL Shimizu published it from Japan. So they now make a 360 micron orifice in the central part of the optics of the ICL. So you don't need the LPIs. We used to have to make 2 LPIs at 1030 and 130 to avoid the angle closure, not with the B4C. So now the EVO, which is the B4C, allows you not only the problem of not having to worry about the LPI, but the cataract rate went all the way down. Because now there's circulation of aqueous around the ICL, and it preserves the integrity of the anterior capsule, because it's an anterior subcapsular cataract that you normally get with the ICL. So that was that story. But we started out with forceps to introduce the ICL. Then we got the cartridge, and then we made it smaller. And then we had all kinds of, we know not to use any heavy viscoelastic. It has to be methyl cellulose like OcuCode, which can be easily irrigated out. So that's that story.
Yeah, that's amazing to see how every generation it got better and better and better.
These products continue to change and improve. And that's what's so neat. Now, we have great relationship also with the FDA. And with the ICL study, we took our project to Gaithersburg. And we met with Malvina. We talked with the people there. They were, of course, had a lot of questions about our center here in the DR. And of course, they checked it all up and down, and we did great.
Yeah, it's amazing how you can work with so many of these companies to get these new technologies approved so we can use them in our operating rooms.
Right, and you think they all work, but there are times that during the R&D they say there's no way you can go on from here. This is something that you need to change the material, the design, or do something. In research, by the way, the worst are the people that invented a gimmick or a gadget, because they think it's their own child.
That's their baby.
That's their baby. Of course, you can't change anything on my child is perfect. And many of these investors, the first thing that they do is they buy the product away from the inventor, because otherwise they can't change it.
Right.
Because they don't want it changed. It's a problem. But if you want to get it out there, you need to change it.
Yeah, but we've seen this in a lot of companies that I've worked with. The version 1 of any product is okay. But version 1.5, 2.0, 3.0, it gets better and better every generation.
They do.
So you really have to be amenable to evolving your product.
Right. The ICL is the perfect example, because they started out V3, too many cataracts. They went to V4, but you still have to do an LPI. They made the little hole. Now you don't have to do the LPI. Cataract rates kept going down, down, down. The improvement in vision went up and up and up. And wow, now it was 1996 when we did our first ICL.
Wow, long time ago.
Uh-huh.
That's coming on 30 years, my friend.
In the way, one of the neat things about research was that I trained 275 U.S. ophthalmologists on how to put the ICL in the eye.
Wow.
And that made for me being able to make a lot of friends. I would be on the teaching side, but I would do the first case, and then we had 9 more. So there were 3 ophthalmologists. Each one of them would do 3 of the cases, and they were able to learn. I was supervising them, and I can tell you, I've seen all kinds of things happen. If you think resident teaching is interesting, wait till you do it when they're graduated.
That's probably even tougher, right? Because they're set in their ways.
But by the way, that there's an interesting comment on that, because U.S. surgeons are they stick to protocol, and they're easy to coach in general. For most teaching hospitals, European surgeons and Latin American surgeons are a different item.
How's that?
The European has this, I'm the professor. You can't tell me how to do things because I know. And so just to give you an example, listen, the wound for the ICL is 3.2. Oh no, I'm used to 4.5 millimeter wounds, so that way I can just do anything I want in the eye. You don't even need a cartridge. I said, no, that's not the idea. The inflammation goes up, you get more cataracts. No sir, you can't do flat chambers. It goes on and on. But yeah, you can't tell her professor what he has to do, and that happens in Germany and Italy and Spain, any of them.
Yeah, that's the effect, though. But we soon realize, as we become more and more experts in our field, we realize that I know less and less.
There's so much to be known. But you know what? That's being humble too, because you know a lot, and I know what I know. But over the years, you end up gathering a lot of experience. And today's example is going to be a good one, because what I'm going to show today, I learned from Ariel Blanco just a year ago, and well, I thought I knew how to do a nice white cataract, and I was doing it perfectly well. And lo and behold, I was not doing it right.
Well, that's the thing, is we're going to keep learning. We're always going to keep evolving that. In fact, that's the reason behind Cataract Coach, is that 5 minutes a day, hey, maybe you'll pick up an interesting little pearl.
That's right. That's right.
And then over the course of a year, that's a lot of great pearls.
That's right. Well, that's how you become a better. I learned to become a better surgeon, phaco surgeon, doing the femtosecond study with the catalyst. Why?
How's that?
Doug Koch coming down to do cataract surgery with me, Buddy Culbertson with me, Don Donenfeld coming down to do cataract. I mean, I saw all these guys doing cataract. I said, man, I would pick up things here and there from each one. Bobby Osher came down. Julian Stevens came from London, so we were in surgery together. I mean, it was an experience. And there were things that I was doing that I thought were great because I was getting great results, but they kept improving.
You can always.
I'll tell you one little trick. One pro.
Tell me.
One time I was doing phaco using the Centurion. I was getting pretty good results. And a week they were all 20/20, but somehow my cases the day after were 20/30 and 20/40 because I had a little corneal edema. So I visited Virgilio Galvez in Bucaramanga. He's in Colombia. And Virgilio runs a huge program, residency training program. The two biggest ones in Latin America are his and the one in Barranquilla with Dr. Scaff. And I said, so I saw his post-ops. There were 8 cases that he had done. They were all 65 to 80 years old. And they were all 20/20. And the corneas were pristine. So I knew he wasn't messing around with little cataracts. It's not the fact that they had, grade 1, 2 Lux cataracts. These were cataracts. And so I go and pull him aside. I said, I know how you operate, and I've seen you operate, and I know how I operate, but my cases are coming out 20/30. And if I do well, I'll get a 20/25. I'll never get a 20/20 the next day. And he said, what do you do at the end of the case? How do you treat him? I said, no, I don't treat him. I use drops, and I do not use any subconjunctival agent. Well, that's the point. You need to put Vigadexa in. I said, do what? So Vigadexa, it's Vigamox with dexamethasone.
Subconj.
No, intracameral. 0.1 ml. So I came back here, and Alcon did not have Vigadexa in the country. And by the way, you just pull it out straight from the bottle. You don't have to have the pharmacy prepare it or anything, because it's already
ready to go.
Ready to go and sterile when you're in there. And it doesn't have any preservative because they don't use preservative in the Vigadexa. That's why you can use it. So I would add at the time 1 ml of dexamethasone to my 5 ml Vigamox bottle.
Okay.
So I had Vigadexa at the time, and it changed everything. Now you see my cases the day after. I said, no way. They're all without edema, without anything. It's just simple Vigadexa. And if you and I don't see TAS ever. TAS is gone.
Wow, so great little pearl. Now you need one of these compounding pharmacies to make it for us.
Well, no, they got Vigadexa. You buy
in the US?
You don't have it?
I'm not aware.
So it's your bottle of Vigamox.
Right.
It's preservative-free moxifloxacin. You add 1 ml of dexamethasone. Remember, it's 4 milligrams per ml. So you take 1 ml of that, you put it in the bottle of 5, and you get the right concentration of dexamethasone plus the moxifloxacin.
Just shake it up and draw it from the bottle. That's it.
You go with your needle, the large needle, a 23 gauge needle, into your bottle. Pull out a good amount of the
mix,
moxifloxacin, and then you mix it with your dexamethasone. That's all you have to do.
Oh, very interesting. Yeah. So what a great pearl from from Professor Galvis from Bucaramanga,
And then he
Colombia.
published it. He published all that. So the incidence rate of his endophthalmitis also dropped by a factor of 12x. I mean, it's really it's really neat. It came around the time when they did the work at Arabian. Remember, Chang went to Dave Chang visited the people in Arabian. I think it was Sri Ramasan or Arabian, one of them, and they did so many others in Nepal. And they were doing extra cap on one side and they were doing fake on the other eye. But then they started also the work with the amoxicillin and intracameral at the end of the case. And then they dropped the rate of endophthalmitis by a factor of 12. And you say, wow.
Yeah, no, for sure. Here in the U.S., for sure, I'm putting amoxicillin and the AC at the end of the case as well, for sure.
Sure. That came out of that. That was from Arabian. But they weren't putting the Dexa. They were just doing the Moxie.
But it just shows you we've got to keep evolving our technique. We can't be too set in our ways. Got to be open to new suggestions.
And it keeps evolving. That's right. Yeah. And that's why I tell my kids, I say, I teach you how to learn. I don't teach you how to do things. I teach you how to continue to learn. And if I were to do the same things I was doing 40 years ago when I graduated, I'd be so far behind.
Right. No, for sure. Because we don't operate the way we did 10 years ago. And in the future, we're not going to operate the way we do today.
No, sir. No, sir.
So what do you think the future has in store for us 10 years from now?
I think we'll have to come up with something better than the phaco, the ultrasound, to do the cataract. I think we'll get to that.
What do you think that could be?
There's got to be a better way. Something that can be see, we are so blessed with our hands and being able to stay in control of what we do,
right?
To do the Rexes, and there's got to be an easier and better way of doing all that.
I think, well, obviously I have an input here too. I think it's going to be something robotic.
Yeah,
I think that's certainly coming down the pike. But I also am excited about new IOLs. I mean, now that I'm solidly presbyopic, I'm really hoping for an accommodating IOL in the future when it's my turn to be a patient.
What I have seen, buddy, we're nowhere near that.
Not yet, huh?
No, sir. No, we got to use some other. I've tried the fluid lenses, and it's just too big. We got to come up with something simpler than that.
Oh, so you think the physical size of the lens being too big?
It's too big. It's too huge.
But it's the same size.
And we're good surgeons.
Crystal lens.
Well, but the crystal lens is not accommodative. You know that.
No. I mean, your human crystalline lens.
Okay.
Is 9 millimeters by anterior to posterior at least 4 millimeters. It's a big. My human lens, my phakic lens is pretty big.
Yeah, but we don't have to put it in there. It's there. It's the problem putting it in there that is a problem.
Right. Well, that's the question though. Should we be collapsing the capsular bag? Because right now what we do is we take out this human lens. It's 4.5 millimeters thick. We put a very thin IOL on the bag, and we give it a couple of months for the capsular bag to shrink, wrap down, and collapse the bag. Is that what we should be doing, or should we keep the bag open?
Well, mind you, when we were doing the Lensgen study with Rob,
all
those cases where we kept the bag open and they have a ring with a Plano lens in the back against the posterior capsule, and then within that ring, which is kind of like a rubbery material, we put the optic plate with the proper correction for the patient. Those capsules, and now we've been 45 years out, are perfectly clear to this day. Why? Because the anterior capsule doesn't drop back on the posterior capsule. And that's what creates the adherence, and that's the invitation for the opacity. Plus, the plate lens was keeping contact with the posterior capsule so the epithelial cells could not get underneath it. That I know is the deal.
So that may be good future kind of planning, that maybe that's probably the better idea. You avoid doing a YAG capsulotomy in everyone. You don't have shifting of the vitreous then.
The other thing that would be neat is if we could do the phaco-ersatz thing that Jean-Marie had always talked about, where you make a little orifice, clean the lens, and then somehow fill it up with fluid. Problem with the fluid is that you just can't fill it up with fluid, because what happens when you opacify the capsule? I
Right.
mean, and how do you keep the fluid in there without seeping out? I mean, there's got to be something better. I think we are probably going to be able to do a parachute maneuver like lens that you can inject and inflate into the bag. And somehow,
Oh, so a collapsed lens that you put in the bag and then you inflate it in the bag.
yeah, yeah,
Oh.
something like that. Or some material that you can create a lens with by whatever.
No, I mean, all fascinating things. It's just like it gets the mind thinking, like, okay, what are these possibilities? So I think that's
But
fantastic.
then the tendency right now is to making these huge, bulky things that I'm a pretty good surgeon, and I feel like I'm putting a frog inside the anterior chamber at times with all these legs sticking out, and you're saying, come on. I mean, there's just no way the average surgeon is going to be able to do that. I mean, they have hard enough to, with two little haptics putting them in the back. Can you imagine all this paraphernalia that come around, and you have a lens ring, and then you have to put the struts, and then you got to line them. Oh, no. And then you need to have an OCT almost intraop to make sure that it's in the right place. No, the average surgeon is not going to go for that. They want their 10-minute cataract and get in and out.
So we got to keep it simple. We can't make it a more complicated procedure.
No, it's just, and then of course now you have an FDA and a Medicare. The Medicare doesn't want to pay a bit more for anything. I mean, make it simple, guys.
Yeah, that's one of the challenges. Now, tell me, how does your charity hospital do funding then?
No, it used to be up until 2008, where we were able to make ends meet by making low-cost materials. We'd bring lenses from Aragon, unexpensive viscoelastics from our lab, this and the other. In 2008, we went into the universal health insurance in the entire country.
Okay.
So now 100%, 92% of the Dominicans have a little card with an insurance. Now, if you're poor, if you're like Medicaid, you go to Medicaid hospitals and clinics. And our hospital is a Medicaid clinic. And we get reimbursed for operating on the poor. And that didn't used to be real. So between 1985 and 2008, we would wing it, but we would make ends meet.
Wow.
This also made for the possibility of being able to pay our surgeons better. Because now, instead of them going in and donating a day of the week for nothing, they're actually being part of our teaching, and they get reimbursed for doing what they do, including the teaching cases. So that's really made a big difference. Our volume really crept incredibly high after the pandemic.
Sure.
All the government hospitals had to be converted over to COVID-19 hospitals, and nobody had a place to go for eye care or eye surgery. I lined up a very neat system where distancing and number of patients, we would do all the screening, mask, a full uniform for all the people in the staff. By November 2020, we were back up and recovered from everything that had happened. We only spent 1 month in quarantine in the country. And there were countries that were out of commission for years and 18 months. Argentina was shut down for a year and a half, shut down.
Wow.
And we were like pumping tourism into the country in November of 2020.
Wow, that sounds fantastic. So the total volume, if you're doing 1,000 patients a day, so let's say at least 300,000 patient visits a year, you must be doing also like 10, 20, 30,000 surgeries a year?
We are doing cataracts alone, 10. And plus, we're the only retina center also for the entire country. We do 9 retina vitreous cases a day. We do about 35 to 40 cataract operations a day, and probably between 9 and 10 glaucoma procedures daily.
Wow, that sounds fantastic.
Where we struggle is with the corneal transplant issue. We are way behind on that, mainly because that's a tissue thing. We can't get tissue in the country, so we have to bring it in. 2 weeks ago, American announced that they weren't going to ship the corneal tissues anymore. They used to do it as a compassionate thing, and they would do it for free, but not anymore. Now we got to send them FedEx.
Well, or your next project, you have to get one of your graduates to start an eye bank, the DR eye bank.
Oh, my son, that's what he does. But we need to convince the people that they have to donate their eyes. I did the law way back in early 2000. So we have a law. It's a cultural thing. It's a something where, and it's not religious. The Pope said it's okay to donate your tissues. That's not a problem. It's more of a, respect my dead person. How am I going to see my way to heaven? It's more of that sort of thing than anything else.
We got to convince them. If your corneas are still here on Earth, you'll continue to see.
Yeah, that's right. You know what the worms do with that.
Right. You're better off having your corneas continue to live on in someone else. I mean, I'm a donor for sure.
That's right. And my father's corneas, my mother's corneas, my sister who passed away from an accident, we used them as an example of what could, and we use them in very poor people. But the problem is that it's still not something that is acceptable. I mean, I've had people on the waiting list for corneal transplant who come in dressed in black and say, "What's the problem?" "Oh, my aunt just passed away. I'm very unhappy." "Oh, didn't you request the corneas for her from her?" "Oh, I should have thought about it." Get out of here. I mean, you need the corneas, and you mean your aunt died and you think about asking for the corneal tissue? Come on. But yeah, this is not part of the traditional funeral service.
Right. So what are the other big challenges that you face here? Because, I mean, it's just amazing how you built this small clinic into something so humongous now. And you're from your residency program from nothing to 10 residents a year. What are the unmet needs here for you?
So right now, for us, I mean, we're building a new building to expand our surgery. And what has happened in the two large cities, being Santo Domingo and Santiago, we have plenty of technology now, and surgeons willing to operate. Our problem is going into the smaller towns in the interior. People only 2 hours away, they have no place to go for eye care. Santiago, which is the second largest city, we have close to 4 million people in Santo Domingo. They're 1.5 million. They don't have a place where the poor people can go. So my next one, if I have enough years left, would be to start something similar to what I did in Santo Domingo and Santiago, and then to build smaller satellite clinics in the smaller towns, meaning towns that are about 200, 300,000 people. Nice. And we're small enough that distances are not such a big problem, but sometimes culturally, distances are, people in the agricultural village, they don't go to the big city, they just stay home.
Right.
They don't want to go anywhere. You see that in California, probably.
Right. And so you'd set up basically another satellite, let's say in another bigger city,
another territory,
small little clinics in smaller areas.
We have 4 small ones right now, and boy, are they busy. They're seeing 100 patients a day, and they grow the same way. They just keep growing. I mean, Norton used to tell me that, "Juan, in eye care, remember the realist. I buy everything around you. You will grow. I mean, forget about it. You will," and this is true all around the world. Just you will grow.
Right.
And so you have to keep your mouth. Then it becomes a problem of quality control. The second thing I'm going to do, I'm going to start a training program for the paramedical people. See, in the States, you take it for granted because you have all these RNs that are greatly trained and your optometrists, right, techs and all that. We don't have anything like that around. So I'm going to start it's called Franja. Franja is on the sidelines. So I'm going to build up the sidelines so that we'll be able to get good technicians and techs and nurses and administrators who know what they're doing.
Well, it's so important because, we realize ophthalmology is more like baseball than it is like golf. It's not a solo sport like golf. It's a team sport.
That's right.
And so for you to perform well, you need a great team.
Yeah, you can't do what I wouldn't be able to do the volume that I do if I were to do it alone. I need about 18 people around me doing what I need to have done. Otherwise, I can't function.
No, that's very, very true.
And you don't need, I remember one of the 2 things that I learned, and you probably know this as well, both Dave Brown and Gills, and they were the champions in volume in the United States for a long time at Donenfeld. And they said, "Well, you need 3 ORs because 2 ORs aren't enough." And Gills went back, took his clinic up to 3 ORs for himself. And after about a month, he said, no, I'll go back to 2. And why? Because when you go to 3, there will be an OR that's not doing anything at all, waiting for him to finish in the other 2.
Right.
And so it was inefficient. He said, no, I do better with 2. And I just fill out my hands and make the people go, and I get things done. And it's true. And that's the way we do it. Then I learned from Arvin the swinging the microscope from one side to the other. So I would have 2 beds. I would be working in one, do one patient, finish the case, and just bring a microscope over to the other side. You learn a lot of little things that make you more efficient.
Yeah, I mean, I just came back from Rio at the Brazilian cataract refractive meeting, and some of these high volume Brazilian surgeons are doing unbelievable volume from one operating room. They're doing 12,
I confuse him with Pavarotti. I can't remember his name now. He's an Italian last name.
Neto Rosatelli.
Rosatelli he's amazing. The guy's amazing.
He's a prince of a guy. We've had him on the podcast before. He's so good.
And he is outstanding. He starts spinning that little nucleus around. I said, come on, guy.
The Brazilian spin. I love it. No, that's such an incredible talented group of surgeons. And they have a big backlog in their public health system. And so these very, very talented surgeons are doing incredible volume. I met so many surgeons in Brazil who are doing 2,000 or 3,000 cataracts a month. One surgeon.
So I was involved a lot with the politics that was going on way back in the early 90s. And one of the problems in Latin America is that the ophthalmology communities locks elbows. And they say, this is our thing, and we don't want anyone else to mess with us. And their deal was not to train anyone, not to train any ophthalmologists. And if they were trained, not to teach them how to do surgery. In other words, I will train you, and they call it the warm water versus the hot water. And of course, they had this thing that if you had the hands, and the hands were a gift from God, then you could operate. And I said, Bologna, you need to train these people. Otherwise, and it's not the hands, it's teach them the right way, and they'll be able to do so. And so Brazil changed its philosophy. Thanks to the government. The government decided to pay for the cataract surgery, same as they did here. And they were the first. And when the government said, no, we're gonna pay you $600 for a corneal transplant, we're gonna pay you $200 for a cataract, but get it done. Get it done. And so they started having these amazing clinics. Sorocaba is an example. Sorocaba not only is a great cataract clinic, they supply at a rate of 1,000 buttons a month Sao Paulo, which is only an hour and a half away with corneal tissue.
Wow.
And you know how they got it? The Sorocaba clinic owns the funeral homes.
There you go. That's thinking.
And if you donate your corneas, you get a free funeral service.
You got to implement that in the DR.
I know. I need more time for that. I don't want to mess with all those dead people.
Well, you've got so many projects going on at a time. You're a great example of, if you want to get something done, ask someone who's really, really busy.
We make it happen.
Right, because you're so used to juggling many things at once that it seems almost effortless for you to add another project.
Yeah, well, that's true. You learn a lot. And then one of the things you learned also, Uday, is that people aren't willing to change easily. That is one of the hardest things. What do you mean? When you see something so clearly, you have a vision of something that's going to make things better, but making people accept that and adopt that, and it's not that easy. People don't like to change the way they do things. They like to keep doing things the same way. It's been always a problem.
Yeah, people. I see that people sometimes get set in their ways and don't want to change at all. They want to do it only this way.
Yeah, I mean, for example, just to give you an easy one, why does Germany have 6% premium lenses only? 6%.
I don't know.
I mean, in Australia, if your surgeon decides that you need a lens, be it trifocal, bifocal, monofocal plus, or monofocal, that's a surgeon's decision in the best interest of the patient, and the insurance pays for it because that's the lens that you need. I mean, you don't go to the optical shop and say, well, give me the cheapest lens. Well, it's a monofocal, but if you want ads in the bottom, that's extra. And if you want something that's extra, and I said, no, you give me the lens that I need because I want to be able to see. And all of a sudden, the premium lenses have become, $1,000 more, and the insurance doesn't want to pay for it. And you know the story. In Australia, that's baloney. Everybody gets whatever they need. And they all of them, 75% of them have an aura to determine if they need to exchange the lens right there in the OR. I mean, it goes on and on. It's a different mindset. And so how do you make people change it? It's not easy. And let's not get into the industry side of things. Of course, they don't want to change either.
Well, that becomes a challenge too, is, as we keep getting more and more technology advanced, our surgeries, the cost of the surgery becomes more and more expensive.
Yeah.
You start adding on some sort of premium lens here. Now you add on fancy equipment in the operating room. You're looking through a microscope that costs you $100,000 or more. You want to use a femtosecond laser using the newest generation phaco machine. It's easy to spend $1 million setting up an ophthalmic OR. Easy.
The one time Willie was alive at the time, Willie Hunter, who set up the clinic here. And we wanted Alcon. Alcon, when we started, used to donate all the lenses, all the sutures, all the viscoelastic, and all the BSS that we needed for the charity hospital. And then Alcon changed. Then it no longer was willing to donate anything. The amount of donations went way down. Yet Alcon was at 66% or 68% of the U.S. dollar in the ophthalmology market. So they had 2/3 of everything was Alcon. And so we went up to the vice president of Alcon, and he said, look, I know that it's only $8 to make a lens. And I know that there are countries like Japan or Europe or the United States where they can pay $150, $200, $300 without a problem. But there are people out there in India or in China or South America that can't afford that because they're not making that much. When Indians make, people in India make, I think it's the equivalent of $50 a month. That's their base income. So I mean, you can't charge them anything beyond $50 because they won't be able to pay for it. So the response, and I can remember that, is he did not answer the question. He answered with another question. He said, why would I sell a lens that I can sell in Japan and Germany for $300? Why should I sell it for $20 elsewhere? Mm-hmm. Why? And then, of course, there you get into a philosophical because we work for the people to see better or whatever. Well, they're not in the business to make people see better. They're in the business to make money.
Right.
So it's a hard one. And then the person who broke the eyes was Binkaswamy in India. And he said, no, this is for the birds. We need cheap lenses for our patients. And we will make a cataract kit, including the IOL, and we will make it available to them for $5.
Right. That's how they started making their own lenses.
And they made their own lenses. That's how it happened.
So no, I totally get that. I mean, sometimes we're at odds with that. Like I said, we're getting more and more and more expensive. I mean, look at the U.S., the amount that Medicare is paying every year for intravitreal injections for anti-VEGF medicines is more than they're paying all ophthalmic surgeon fees combined.
That's right. And that's crazy.
Right. There's got to be some limit there. So I don't know what the right answer is going to be, but the balance seems to be askew. It seems to be off.
Yeah. But then the reason Alcon was bought over by Novartis, the reason is that Novartis has figured out that for every $10 that they invested in eye care, the return for surgical components of ophthalmology, the machines, the lasers, the instruments, the microscopes, was free for the $10, 30% return. But if the investment that they would get, or the return they would get on the $10 if they invested in the pharmaceutical, was astronomical.
Mm-hmm.
Astronomical, 30 to 10, 3 to 1, 10 to 1. So they bought Alcon. They ripped off all the pharmaceuticals and they said, take it back.
Right. Yeah.
That was the maneuver. And they kept all the Genentech things and all the pharmaceuticals that were worthwhile and say, okay, take it back. The Alcon is now, but Alcon started with Alexander and Conway making little pilocarpine bottles and cyclogel bottles and TP bottles for the doctors to buy them at the academy. And they became an ally of the physician, meaning whatever your needs are, we will make. And then we made BSS, and then we made viscoelastic, and they would always serve the surgeon. It was an alliance. And of course, when Novartis to forget the alliance, this is a business deal. You're here to make money. We don't care about you.
Yeah, that's an odd thing, you know?
Yeah, get out of here. Then I don't understand the US FDA. The FDA, for me, is a puzzle because they have paralyzed the development of so much technology in ophthalmology. Paralyzed it for 12 years. The only thing that got through was the glaucoma.
Mm-hmm.
Almost 12 years. Not a single device went through. The only one was that glaucoma valve. I mean, there was so much research going into devices. So how come? And yet all the rest of the world, they're doing pressure flows and this and the other. I mean, there's so much technology going that we're not even close. Not even
right. I just had a video on CataractCoach about the iris clip lenses for aphakia, which we don't have in the US.
No.
And or where do we get these? We're never going to get them.
No. The Vigadex is a good example. I mean, you can't have trying to get anything through pharmaceutical in the States. And then the research money, the amount that you have to invest in research is phenomenal as well. To get anything back, sometimes there are just great things that happen and work that they said, no, it's not worth it. Why would I have to recertify that? What's no point? I don't understand. But then Phil Rosenfeld in Miami learns that bevacizumab Avastin is just as good as Lucentis.
Right.
And they have put so much money to show that Lucentis is better, they've not been able to show it. But you know how they handle it outside of the U.S. and in the U.S.? Well, we're not approved. We're not FDA approved for the bevacizumab to be used in the eye. We are only approved to have it used in the colon for colon cancer.
Right.
And so you go to your regulatory agency, listen, I can buy the Avastin and I can treat with one vial of $75. I can treat, 75, 100 patients. So just let me do that. I said, no, it's not approved for that. And who allows it to be? Well, the company would have to subject it to the government for federal approval. Are they going to submit? No way. They're not going to submit their own drug to compete with their
other one, yeah.
$1,500 product. Forget it. They're not going to do that.
Yeah, ultimately, then the patients lose.
Yeah, the patients and the insurance companies and everyone. Rosenfeld and he and I had, how you have these bathroom conversations that you both go and find yourself in the bathroom. And I said, I asked him, this was way back when he started doing the Avastin protocol at Best and Palmer. I said, Juan, you're not going to believe it. Every year, the United States at the time, they were doing 1.5 million intravitreal injections. I think it's up to 3 million now or something like that. And most of them are Lucentis. I said, come on, Phil, but Avastin is so much cheaper. You would think they would. That's precisely why. Because when a surgeon injects a Lucentis, he gets a $250 check. And we inject Avastin, and he gets a $25 check. So guess which one he wants to inject?
Ay.
So come around. I mean, it's a dollar thing that it works against us. But that's the reality that we have to live with.
Yeah, it's a tough thing to balance, best for the patient versus the companies have their best interest. Like you said, it's to their shareholders or making a profit. It's not necessarily what's best for patients.
No.
But ultimately, as physicians, I think we have to, the onus is on us, is that we have to first say, okay, let me do what's best for my patients. Let me do what's best for my community. Let me do what's best for my clinic, and not worry so much about what's best for the companies. They'll figure out their own. So as best that we can.
No, I know. I don't get frustrated anymore. I used to get frustrated with it. I finally found that, well, if this doesn't work, I'll just do it another way. For example, the catalyst, we could do anything with the catalyst. Even the black cataracts we can would do with the catalyst, and the white ones. I mean, it's great. This would be this white cataract story. We had a femtosecond. I mean, it is designated for that. But who gets a white cataract, the poor or the rich?
Yeah, of course, the poor patients.
The poor. I mean, can they afford the extra $500 that you would have to charge for the femtosecond? No. So finally, about 3 years ago, I stopped using the femto. I said, what am I doing working for Johnson & Johnson? Get a hold of that. I mean, I don't need it. I can do it with my hands. I don't need to worry about the Rexes.
Well, now we know, just use a 30-gauge needle without the para. Just right through the limbus into the lens capsule.
That's right. Wait till you see the video. And it repeats itself.
We'll feature the day after your podcast. If you're listening to my podcast, the next day, tomorrow, we're going to feature the video of this white cataract and this technique. So it'll be fantastic.
That's right.
But I think I just really admire the work that you've done over the years. Like, you're the ultimate professor. You love teaching. You've expanded your teaching hospital from such a tiny thing to such a huge thing. And then I also love your commitment to advancing technology and working with all these companies to, develop and get approved everything from glaucoma devices to IOLs and phakic IOLs and femtosecond lasers, and you name it. So it's really impressive.
I love it. Every time they come up to me with a new project, my research leader, which is Maria, said, "Doctor, I'm glad you weren't a woman. If you were a man, because had you been a woman, you would probably been a prostitute. You just say yes to everything."
Well, you know what? Listen, I think we both have an enthusiasm for wanting to see all the latest toys. Ophthalmologists in general, we're gadget people. We love the toys.
That's right.
And so any new toys or technologies that come, I think we always want to get involved. We always want to learn more. And, I still have not visited you in the DR. I need to make a visit to the Dominican.
Yeah, you would love it. You're invited. Then we'll go to the beach together or go up to the mountains. I don't know what you like better, the horses or the beaches.
You can probably do both in the same day. That's the best
Not
part.
the same day. You need to enjoy it. There you go.
Well, that'll be fantastic. Well, Professor Juan, thank you so much for doing this podcast. I want to really give you my sincere thank you and gratitude. Always learning so much from you. I know we're going to work together too. I got some project ideas in ophthalmology, which we'll hopefully explore there in the DR. Thank you.
I'm delighted. Thank you, Uday, for having me.
Oh, my pleasure. And if any of our viewers are interested in learning more about Dr. Batlle, we'll put some links down below. You can check it out, see his hospital, and maybe give him a visit too.
Here we go.
And then finally, I want to remind my viewers and listeners, remember, we got a new podcast every single week. You'll find on Apple, Amazon, Spotify, Google, YouTube, anywhere you get your podcast. We also have a new surgical video every single day. And then tomorrow's video of the day is going to be Dr. Batlle explaining us how to do those challenging white cataracts. Until next time, take care.